Vlasis, please.
Thank you very much. So it's a recorded case that we did in April. And this is a male patient, 68 years old, with ischemic cardiomyopathy, previous posterior lateral myocardial infarction, and functional mitral regurgitation with some degenerative components. Severe MR, these are the risk scores when it comes to STS. Not very high risk, but there was some morbidities on these patients, and the main one was COPD, and also the fact that the patient had mostly functional mitral regurgitation. So the 6-minute walk, the pretest was, you can see, I don't see the distance, 288 meters. Pro-BNP was elevated. Other than that, the previous medical history showed inferior myocardial infarction, multivessels, coronary disease, and he was on the maximum tolerated medical therapy for heart failure. So you can see the transthoracic echo. So you can see there is an element, there's severe MR. So there is some prolapse or pseudo-prolapse of the anterior leaflet. So we're not sure if there is some excess tissue there, or it's just restriction of the posterior leaflet. But at the site of the regurgitation, there is a speckle of MAC that actually is there, potentially interfering with the potential TEER procedure. You can see that from the 4-chamber view, regards than fraction 46%, regards than volume 82 mils. You can see the 3D, this speckle of calcium from the ventricular end here. And you can see the hypokinesia of the lateral wall due to the previous myocardial infarction. Aortic valve is okay with some trace of AR, mild tricuspid regurgitation with not highly elevated PA pressure. Right heart cath showed the systolic pulmonary pressure of 50, but elevated wedge pressure with a V wave of 43. So it's a post-capillary pulmonary hypertension with a cardiac index of 2.1. So not too bad, but this is consistent with the mitral regurgitation. So this is the AltaValve that we previously mentioned as part of the early feasibility trial. The patient was screened. So this is a supraannular device that is atrially fixated. It has this nitinol cage that is passively opposed against the left atrial wall with white cells that can accommodate 24 French of catheters. The bottom part of the valve is opposed against the mitral ring and is covered by PET scare to mitigate any PVL. And the three sizes that come is 40, 46, and 54. The valve itself is positioned in the center of the implant. It's a bovine pericardial valve, 27 millimeter, and is the same size for all implants. The true ID is 27 millimeter. In terms of sizing and patient screening consideration, we use the mitral annulus as size. You can see it from the CT, the calcified zone on the MAC, which is in the region of interest. And you can see that the diameter is about 44 by 40. It's a relatively circular diameter, which is good. And we thought that the 54 millimeter annular ring, the biggest annular ring, is the appropriate one, oversizing to the anteroposterior diameter by 37% and the commissural diameter by 27%. We look into the LV, but mostly we look into the annulus and the MAC. You can see the MAC that it dives inside the LV from the profile view, but it's a mild MAC if you look at the MAC score. And the most important is the left atrium. So we look at the size, height, and width, and we look at the anterior tilt angle. Also, volumetric changes during the cardiac cycle, which is 9.2%. If it's more than 20%, we steer away. And also, we look at the mitral annular motion, which is 6.3 millimeters. Anything above 15 millimeters, we steer away, at least in this particular stage of the development. So looking at all that, we decided about an implant of a 54 on the annular ring and 75 by 80 on the cage. That will give us a height oversize around 15% max and width oversize about 20%, which is just about what we need for an implant. Transeptal puncture needs to be above 3 centimeters. We have a projected between 3.5 and 4 centimeters. We go posterior and inferior. And the procedure is quite straightforward, really. It's a single stage. So transeptal puncture, inferior posterior location, balloon septostomy. introduction of the steerable guide catheter, steerable sheath, then the delivery catheter through the sheath. The catheter is flexed down to the mitral valve, and the deployment starts from the mitral annulus level to the top of the left atrium, and then release. The important thing to say is that up to the final stage of the procedure, before actually detachment of the delivery system, the valve can be resheathed and repositioned up to 3 times. So it's a versatile procedure. So the setup is primary access right femoral vein, fully percutaneous, left femoral artery for arterial pressure monitoring, and also to be ready for hemodynamic support, left femoral vein for temporary pacing, because you use some fast pacing, not rapid pacing, right radial for LV pressure monitoring, and of course 3D echo, fully percutaneous approach. So you can see using 2 proglides and a figure of 8, we have obtained access from the right femoral, inferior and posterior puncture, and 3.8 centimeters height we achieved. So this is transeptal puncture, a Landerquist wire advanced into the left upper pulmonary vein, and then balloon septostomy. We only use an 8 millimeter balloon because we just want to facilitate passage of the steerable guide catheter, nothing more than that. Then we pre-dilate the groin with some dilators up to 24 French, and the 29 French steerable guide sheath is actually inserted and advanced through the atrial septum. You can see very clearly on the echo on the top left. Once we achieve this position, we put it on the stand and we take out the dilator and the wire, similar way we do for the TEER procedures. So wire comes back, dilator comes back, and we just aspirate and we take it out. Then the delivery catheter is introduced under flushing, and the aim is to advance it to the tip of the steerable guide catheter, so align the inner catheter with the outer catheter. So the interesting thing is that there is a dual catheter design. So you have the outside catheter, which is a steerable sheath, and the inside catheter, which is the inner catheter. So when you unsheath the valve, you unsheath both catheters, one after the other. And that gives you excellent control of the position of the cage. But first you have to go down to the valve, and that is done with the flexion of the system. So first you just put the tip of the inner catheter, the implant actually just outside the sheath, the steerable sheath. Then we flex down to the valve in a pre-specified RAO position that you get from the CT scan. And then we just flex down. The flexion is actually quite easy because you don't have to push your inner catheter out. Like, for example, the straddling you do with a mitral clip. All you just have to do is just flex down and observe your tip to be away from sensitive structures. And then once you're down to the valve, you put your imaging to the commissural and the multi-D position, explain, corresponding long axis view. And all you have to do is to go down to the mitral valve, below the annulus, at the depth of about 10 to 15 millimeters in systole. And this is exactly what we're doing here. You can see on the left picture, top left, the position of the frame, which is below the annulus, below, and we measure in systole 10 to 15 millimeters. Once we're in this position, then we unsheath first with the inner catheter and then with the outer catheter. The plan is first to expose the annular ring, which is done, then to expose the inner valve, so the chimney. That has a height of about 25 millimeters. So go just above the tips of the chimney, which you can appreciate on fluoroscopy. You can see the annular ring is already bulging a little bit on the right side, on the top right, on the fluoro. Once you achieve this position, so now the outer sheath is withdrawn and we're being directed just above the tips of the inner valve. Once you achieve this, you shift everything laterally, so you achieve a lateral engagement that you can appreciate on echo next to the appendage. That gives you some stability, so you're rubbing against the lateral part of the annulus. By controlling the height, you can adjust your height, and then all you have to do is open up the valve by 50%. So now you can see there is a function, there's an inner wire that is attached to an inner 6 French catheter, and once you push this wire, which is like a loop, a snare around the valve, you release the valve. So now the valve is fully functional. You can see on the echo, the leaflets are actually moving in the long axis view. So the patient is actually maintaining hemodynamic stability, even though you're just blocking the mitral valve because the inner valve is working. At the same time, we'll just start pacing. And what you see now is in real time. So we are unsheathing the nitinol frame, and there's no editing on that. This is as it's happening. So by removing the inner catheter and the outer catheter and adjusting the positioner, which is this little 6-French catheter in the middle of the assembly going down to the valve, you're just able to deploy your valve. You can see the progression of this deployment on the echo. You can see the cage opening and filling up the left atrium. And actually what we have found, once you open about 60% of the cage and you engage on the lateral and the wall and the atrial septum, the valve remains very stable. So we reach to the top, we push the insertion catheter to the rooftop of the left atrium, and now the cage is fully deployed. And you can see the valve is functioning. Still the valve is snared, so we still have another 50% to deploy. And needless to say, we can resheath and reposition quite easily. But we are happy with the position. The hemodynamics are good. We will stop the pacing in a minute. And right now, you will see on the fluoro, we will deploy the inner valve. So here, I'm just pushing the snare, and you will see the inner valve being deployed fully in a minute. But still, we have the opportunity to retrieve, to resheath. Once we're happy with the position, then we have to deploy in 2 stages. First, remove the inner catheter, the positioner, which we will do in a minute. By pushing in the snare, we have to be extra careful because if you're too fast, you may yank it out, you may snare it out. And of course, you can still resheath, but, you know, why do that? So you see, in a minute, we will take the inner catheter out, the positioner. That adds additional stability when we implant the valve. So it's actually is putting a lot of internal push towards the left ventricle and is maintaining the stability. So that's out. And then in a minute, we will unscrew the valve. So device time on this was 15 minutes. So it's pretty fast. Most of the video is unedited. That's it. And then we'll just take the sheath out. You can see on the echo how the valve is already working. Spacing is stopped. There's no LVOT gradient. You can see simultaneous pressures of LV and aorta. And we're just taking the sheath back. And of course, we need to assess the outcome. So this is how it looks on echo. Supraannular valve functioning quite nicely. Elimination of mitral regurgitation. At worst scenario, you will see some trace of PVL. Left to right shunt. We left this shunt. We didn't close it. There's a big question whether we should close this beforehand or not. No gradient across the mitral valve. These are immediate images from the procedure. So you can see the LVOT is widely open. One interesting feature of the valve is, as you see in systole, is moving actually away from the septum. So it's not protruding at all, but it's actually moving away because there's a work in progress by João Cavalcante that shows that this frame is actually moving with the native mitral annulus. So it's actually falling, you can see that even here, he's moving in systole away from the septum. So the paradox for this, which is a pleasant thing, is that the LVOT area in systole is bigger than in diastole. Not only you maintain LVOT, but you get a better LVOT area. Thank you very much.
Thank you, Vlasi. Impressive. And how many cases have been done so far?
So I think we're over 85 cases worldwide now, starting from the transapical and moving into the transfemoral. Of course, the transfemoral cases now have accelerated since Germany, France, and Spain joined. In Interbalkan, we've done 10 cases, but we're lining up for another 5 or 6 as the pivotal start. And pivotal will start in Onassis Heart Center too. So Dr. Iacovi is PI for that. And hopefully Ioannina University Hospital as well. And maybe other centers in Greece as well. Will be nice.
So this is, really interesting technology. So initially someone would think that maybe it's, why do you bother with the left atrium and not, directly approach the mitral insufficiency, but it's a different kind of concept. So we are not trained to, for that, because we always believe that you have to reach, your target is the solution. So, but this is an indirect method, but with very interesting results up to now.
Well, the interesting thing is that the recruitment rate in the EFS that we reported in EuroPCR and also CSI recently is 77%. So this is way too high compared to any other technology out there. So not only is it feasible, but it's actually realistic. So you can treat a broad range of patients. LVOT is never an issue. LA size is an issue, but really you have to have LA diameter of more than 85 millimeters. So it's not for the small LAs still. MAC is not a problem. So if you look at the pivotal, there's a main cohort, which is the ordinary mitral regurgitation patient, whatever etiology, but there's also a MAC cohort, dedicated MAC cohort for 100 patients. So overall, 450 patients in total.
Except of mitral stenosis, of course.
So far, no mitral stenosis. So the minimum diameter that you need to have on the mitral annulus is 29 millimeter, between 28 and 30, 29 as an average. If you're below that, this current iteration doesn't work. Another company is preparing a mitral stenosis iteration as well, but it's not out there yet.
So this is going to be really interesting to see. So Elias, so you are doing the echo in these cases. So do you have a special challenge in imaging these procedures?
No, I think imaging is simple. It's very simple. It's not a problem.
Yeah.
It's more easy than for a mitral clip. But Vlas, I had a question. Why to prefer that valve if you can put a mitral clip? I mean, which is the criteria?
I think if you have, that is a very good question. It's following what the conversation we had before. So if you have a green zone mitral clip patient, I think you should put a mitral clip or any TEER device because it's safe, it's effective, it's proven, there's a lot of experience. But what happens if you have a red clip, a red zone TEER, then you cannot treat. So you should try and see this technology or others. What happens in the yellow zone? That's the big question. I mean, do you still go for a TEER device, accepting a suboptimal result? What will happen in a year's time or 2 years' time as we move to younger people? I mean, this was a young patient. We could have probably put a TEER here and be okay with it. But this is the discussion that we had before. I prefer to steer this patient to TMVR, and we had a very good result. The patient came for a follow-up at a month and a half, and his 6-minute walk was 440 meters from 280.
Yes.
Do you have any data on thrombosis or?
It means lifelong anti-thrombotic therapy.
No, not really.
Not really?
The regime that we follow and we recommend is 6 months of vitamin K antagonists, Introm, warfarin.
Right.
But then we just move to whatever anticoagulation patients were taking. So that means if the patient is in AF, we move to NOACs, DOACs. If the patient is in sinus rhythm and the EFS, there was a 20% population that was in sinus rhythm, we just move to aspirin. We're not worried at all about the frame. Everybody says, oh, there's a lot of metal in the LA. It's nitinol. I mean, it will endothelialize. It's thin struts with big openings. We put ASD, PFO devices day in and day out, and we don't worry. What we do worry is about the valve itself, which is a biological prosthesis in the mitral space, and that may thrombose unless you give proper anticoagulation as for any other valve. We haven't seen any thrombosis yet, at least not worrying signal.
Is there a plan that in case that you have a deterioration of the valve in the future, especially if you go to younger population, to do a valve-in-valve procedure?
So actually putting a valve-in-valve there is easier compared to putting a valve-in-valve in an annular position because you don't care about the LVOT. I mean, this is a 27-millimeter valve. You can easily put, and it has been done on the bench, transeptally to go through the struts that are very wide, 24 millimeters, and put a balloon expandable 26 up in. It has happened in the bench. It's never happened in real life because it's only just started the experience. But it can be done without any issues, and actually the LVOT will not be affected.
And you think the struts will be dilatable? It's 24, but with the current technology.
Well, 24 means that any 14
Yeah.
French device can go through, but you can also dilate with a balloon and then close. One issue is how will you revisit the left atrium for any other procedure like Watzmann or LAA, for example, or PV ablation, if you put an ASD device. So that's why now we're discussing about putting a cardioform device that has more fabric and less metal in order to be able to perforate it and balloon it, as opposed to other nitinol-based devices.
Good. I don't know if Stamatis is still there. No, I don't hear him. Yeah. Any other comments from the audience? Theo?
I have a question.
Yeah.
Thank you for the excellent presentation. Really, we are learning a lot of things from your presentations and the new technologies. My question will be like the other questions, but you know that atrial functional mitral regurgitation is an issue. During the follow-up periods, when the left atrium gets smaller, is there an issue for the device, or what is your opinion about it? Can we use, for example, this device for atrial functional mitral regurgitation also?
So that is an excellent question, and there are two answers to that. First is, if you look at the cohort, I didn't show it because it wasn't part of the presentation, but the cohort of the EFS was mostly women with atrial or degenerative mitral regurgitation. So small LVs, preserved ejection fraction, big LAs. The reason is because this valve came late in the process of getting into trials. These patients have been rejected, especially in the US, by other technologies, and recruited by AltaValve. So it's very interesting. If you look at the cohort, there is at least 20 or 30% of this population have been rejected because of narrow LVOT, and that has not been an issue. Now, when it comes to the left atrial behavior, there is work in progress, and Nadira Hamid should be publishing that soon from Minneapolis Heart, that the left atrial actually remodels in this population. So you get reduction in the volume, and whatever wall motion was there is actually maintained. So it doesn't freeze the left atrium. The left atrium still, and there's tissue Doppler and other methods. I mean, I'm not familiar with exactly the paper that she's publishing, but it shows, if you look at the curves, the left atrium remodels because the nitinol frame is actually quite soft. So it allows wall motion, as mitral annular motion, it allows wall motion. So that's promising.
So this is very interesting. So thank you very much, Vlasi. You did a